Okay, welcome everyone. I am excited today to have our guest here. We have Chandra Scott, and we're going to be talking about her work with geriatric social work and how she engages with clinical assessments and care planning. So thank you for being here today.
Thank you for having me.
Awesome. So I'm going to go through our logistics. My name is Megan Mitchell. I am currently in Washington, D.C. I have my hands in a variety of different things. I do, in my clinical world, I am a child and adolescent therapist at a private practice in Washington, D.C. I'm also working towards my play therapy credential because I work with kids and teens. So play is very important. I'm the founder of Agents of Change Social Work Test Prep. And of course, we've now moved into the CE space, which we're really excited about. And then I'm also in my last year of my doctoral program at SUNY Buffalo. And in that work, I'm focusing on supervision, multicultural supervision, and cultural humility. So that's a little bit about me. Let me tell you a little bit about Chandra. She's an LMSW in Maryland. She earned her MSW from University of Maryland, Baltimore, and she's been working in social work for a very long time. She has lots and lots of expertise, almost 20 years, which is awesome. She's going to tell us a little bit specifically about her work with elderly and geriatric clients. She currently does some per diem work, working with the geriatric and homebound individuals. And she's an entrepreneur as well, which I love to always have fellow entrepreneurs in here. She's a volleyball mom. She was just telling me about being a volleyball mom to a teenager. She's an author. She likes cooking, reading, crafting, and attending concerts. So thank you for being here today.
You're welcome. Thank you.
And some of our learning objectives for our CE today, participants will be able to apply innovative assessment techniques in geriatric care. So we're going to talk a little bit more about how do you assess when clients are homebound and you might have very limited time with the client. So what techniques or tools do you use? How do you tap into community resources? How do you provide that wraparound care? And then where are there some systematic barriers? What's lacking systematic or policy wise that might prevent someone from helping someone that is in the geriatric population or is receiving homebound services? Why is this important? Our elderly and geriatric population is growing. We know that. I actually think there's probably a huge shortage of people that specify in this area. They required specialized care, their specialized knowledge. So it's important that as this community grows, this population grows, this community is aging, right? We need more people to do the work here. They have particular health and social needs, and we'll talk a little bit more about what those needs might be and how they intersect with health and mental health and societal barriers that they might be facing too. And then how do you give them the wraparound coordination and care that they need? And Chandra will tell us a little bit more about this because she is the expert. So without further ado, I'm going to kick it off to her. So tell us a little bit about yourself. And I know you have an extensive background, but kind of how you landed in this space that you're in now.
Okay. So actually, once I first graduated from undergrad, I had an interest in working in a nursing home. But I found out that my undergrad institution was not accredited in social work. So my major was sociology and social work. So I kind of, it was a little hard finding, my first career site after undergrad. And then I learned that in most nursing homes, they want you to be licensed. So I just kind of forgot about it. But growing up, I was always, helping out with like my grandmother, my older aunts when they got ill. And then my mom fell sick the end of 2014. And the beginning of 2015, she was diagnosed with pancreatic cancer. So, she only lived for 2 months with the diagnosis. And within that short amount of time, we went from hospitalizations to home health needs to hospice, learning about DME equipment. And it was just a lot. And I was like, wow, I didn't even know all about this in social work. So it kind of piqued my interest again. So once I earned my LMSW license, I was like, okay, I want to try my hands in healthcare. Like, it's really interesting to me, especially like palliative care, hospice, and working with the elderly. So I started at the hospital setting, and that was for a contractual position. So I learned about like discharge planning and how anyone who is an inpatient admission at a hospital, you have to have clinical assessments. We go over like your housing needs and things like that to help with your discharge planning, to help you discharge safely to either home, a facility with family, or sometimes people transition to hospice care.
Yeah.
So it was really interesting. And so from the hospital, I moved on to a skilled nursing facility, and I learned more about long-term care residents. I was on the long-term care floor, so all of the residents were, Medicare recipients, and they had already received hospitalization but were discharged because they needed more intense long-term treatment. So they weren't able to go home. So they were in the skilled nursing facility long term. Some were there, you would hope for a few months. Some were there for long-term care, meaning they kind of, did the paperwork process to have, their income received to the nursing home facility, and the nursing home was their residence now full time.
Okay.
So there were two different tracks at the nursing home and on the floor that I worked with. So I had to deal with, you know, you deal with hospice and palliative care, you deal with safe discharges, you deal with care planning, because in the nursing home realm, every resident at a nursing home has to have a care plan, and it's supposed to be quarterly, and it's heavily mandated and surveyed by the state and the federal government. So there's a lot of documentation, with working in the nursing home field as well. And currently, I'm working with a home health agency. So I'm not seeing them on the hospital side. I'm seeing them when they're discharged from the hospital. And now they're being told, okay, you don't have to go to a skilled nursing facility. You can return to your home, but since you're homebound, you need home health services. So you need skilled nursing, physical therapy, occupational therapy, sometimes speech therapy. And then, once they get home and the RN sees them or the physical therapist sees them, they may say, okay, in addition to this, they also need a social work visit. So then I come in and I provide like those extra resources that they may need in the community and help link them with things like if they need meal services, if they need Meals on Wheels, if they need information about food pantries and things like that. Or if they're having issues with their insurance or getting their durable medical equipment, I assist with that. And usually with the home health agency, I work on a per diem basis. So I'm usually only in there once or twice to help. So it's like I have to get in there, get the meat of what's needed, and then I come out. It's
Mhm.
not like a long term process. Whereas if you're in the hospital, someone may be admitted for like a week or, but sometimes in the hospital, you could be there for months. It just depends on your illness. Whereas the nursing home, you're there for months, sometimes years. But on the home health side, it's a temporary service. Even if you're getting skilled nursing and physical therapy, it's only for about 2, maybe 3 months. And then on the social work side, it's only 1 to 2 visits within
Yeah.
that time frame. Yeah.
So a few follow-up questions. So you've kind of seen all of the different areas of healthcare for geriatric clients. Tell me a little bit about the differences, like you said, where you when you worked in the hospital setting, where there's maybe more long-term support versus being in the home and knowing you have such a short amount of time to do what you need to do.
Yes. So in the hospital setting, the main focus is them being medically clear for discharge. That's the number one priority. So like let's say if they have like acute kidney failure, that illness is the first priority. So, do they need like emergency dialysis treatment? They may have to get that in the hospital. And then, as a hospital social worker, you will set up the discharge planning to get them community dialysis once they leave. And we know that dialysis is usually every other day. So, the physician will say, okay, they're medically cleared to leave on a Thursday. Thursday morning was their last dialysis treatment. So, then my role would be to make sure they have their next dialysis treatment set up in the community on a Saturday so they don't miss a day. And
Okay.
sometimes that's difficult depending on the time of day because you're sending a referral. Then that dialysis clinic has to review that. Their clinicians have to review the lab work and With dialysis, you have to have TB testing, X-rays, and show all the progress notes to make sure. And then, if they have other ailments, like if they have a communicable disease or like HIV, they have to have certain seating at a dialysis clinic. So then that's a specialized seat that they have to have, and only certain treatment centers may offer that. So it's a lot that could, be encompassed with discharge planning depending on the illness. Like if they have respiratory needs, you have to make sure they leave with oxygen. They have to leave the hospital with travel oxygen, and you have to set up the transportation to have it delivered to the home that same day, because they oxygen is an emergent need. They have to have that DME equipment.
And so that sounds like a lot of coordination and a lot of being really knowledgeable about what each of your clients needs. And then in the home, the care that they receive or what you are doing for these one or two visits, how does that differ? Because you are in their home and you have such I are your visits 60 minutes? Like what length of time would you be working with them in the home?
In the home, it depends on their need. It could be like 30 minutes, 45 to 60 minutes, sometimes longer. It'll depend. Like some people have like a great support system. Like all of the family members are there. They have 24/7 support. They're never left alone. Whereas some that don't have that support, they may need more community resources to bring in that support to them so that they can stay in the home safely. So you may coordinate like prescription coverage. Some people may need like prescription coupons because some medications, even though it's covered by insurance, there's still a really expensive copay. And most elderly patients are on a fixed income. So I may provide like a prescription coupon. Like one of the top things like Eliquis, like that's really expensive. But fortunately they offer a coupon for it. So that can help for like 30 to 60 days. Or they may have an issue with their medical equipment being delivered to the home. So I may have to follow up with the provider about that. Or, for example, one recent patient needed a bariatric bedside commode.
Hmm.
But I found out that due to insurance, because she didn't weigh 301 or more pounds, she does not qualify for bariatric. So insurance will not cover it. So I left her with a $75 copay. So it's like, okay, she's already on a fixed income. Now I have to troubleshoot, try to, work out, find resources to get her that. So it's just a lot of service linkaging and, seeing what's really needed. And then also finding out the patient's like mental health status, because it could be a lot if you suddenly you're aging in place and you're dealing with a certain illness. You go from like 5 medications to 10 a day, and your kids are grown and they don't live in the home or they don't live nearby. And now you have certain medical equipment to move about the home, where a year ago you were able to walk about your home fine. So it's now simple things like steps in the home. Like one of the questions that we always ask in the assessment is how many exterior steps you have and how many interior steps you have. Because if you're homebound, we need to know that. Like if we arrange for transportation, some medical assistance transportation, they only come to the curb. So you
Ah,
still have to be able to get down from your front door to the curb. So if you have a lot of steps, and if you don't have like a grandchild or a husband or wife or someone there to help you get around, how can you really do that? So I may have to arrange for a stretcher by ambulance,
wow.
which can be covered by Medicare, but that means the ambulance transportation needs to know, okay, we need to have a certain number of staff members to maneuver 5 steps outside, or once we get in the home we need to go up 10 steps to get the patient on the stretcher, then come down. So it's just a lot of coordination depending on what the needs are.
Going into the home, does that give you a different perspective because you can see the physical environment and can assess that way? I've done home visiting in a very different capacity, but I thought that when I did home visiting, it was for early intervention. It gave me so much information I would not get if I saw them in a different setting.
Yeah. So I actually like doing home visits. Like I started off my social work journey was working with at-risk youth, and then I transitioned into foster care in Baltimore City. So I'm used to home visits in any area, and you can tell a lot about a person from their home life. Anyone can tell you anything when you're doing an assessment at the hospital or in an office. But once you see their home life, you can see, like, what other barriers they may have or what other resources they may need. It could be as simple as, finding out about their nutrition, like how did you eat today? Like that's one of my biggest questions when I go in and meet with the elderly patient. Like, have you had, if I'm there at like 10, I'm like, have you had breakfast already? And if they're like, no, I'm like, well, did you at least have your insured drink or something to have some sort of nutrition? And if not, what do we need to do to get that for you? Um, so yeah, seeing the home, you can tell a lot. Hoarding is a big thing,
Mm.
especially with this population. And sometimes it's because they can't physically do the day to day housekeeping. But it's a big thing. And then you're going in someone's home, and I've been in homes where there's barely like a pathway from the door to like the living room, and you're like, you just all you can do is stand there because it's like nowhere to sit or anything like that. So you can definitely tell a lot and see like, are there any geriatric psych issues that we need to explore and help you maneuver through? Do you need more caregiver support, companion support, and things of that nature just by seeing their home life?
Yeah, that kind of takes us into our next topic of clinical assessments. Tell me a little bit about how you can do clinical assessments and if there's any particular considerations you need to take with the geriatric population, because I would assume it depends, as with everything, but what does a clinical assessment look like when you're going into them?
So it's almost like a biopsychosocial. So you're getting all of the background information from the basic demographics like age, gender, race, but diving deeper, like what was your highest level of education? What's your income? Um, you know, um, where did you live before here? How long have you been at this address? Who lives here? Because also with this population, a lot of elderly patients are also caregivers. They're caring for their grandkids, but now they're sick. So now we have, a whole nother dilemma or barrier that we may have to explore there. And then we explore like, have you experienced any type of trauma? And trauma can be anything from natural disasters, like if you were a part of a hurricane or tornado, or if you experience any type of assault, whether it's physical, sexual, or if you witnessed something happen to someone else, that can still affect you. And then we also deal with a lot of memory loss in this population from Alzheimer's and dementia. So what was the age of your onset? You know, and then we know that now dementia and Alzheimer's is really a spectrum, like autism. So every person is not the same. So yesterday this patient may be pretty meek and mild, but today they could be agitated if their schedule went awry. So now they may be heavily agitated, and that could turn into aggressive and violent behavior for some residents, unfortunately. So it's just a lot that we try to explore, and you have to try to do it quickly, especially with the home health population. So I created like a worksheet, and when I was in the hospital and at the nursing home, and even with the home health setting, I try to take that with me so I can get all of this information and summarize it quickly onto like one sheet on a one pager. So I find out about your income. Like, are you getting a pension? Are you getting SSDI? Do you have access to your award letter? How much is that? Do you have like life insurance and things of that nature? Do you have long term care insurance? Because I found out that if you have long term care insurance, that can help pay for private duty nursing and caregiver support that you may need, and it can pay for long term care if you end up going into a facility. So we try to explore everything from finances to how you're feeling. With this population, we have what's called like a BIMS or PHQ-9, and it's like a very short and brief like mental health assessment, and it asks questions like, have you been feeling down lately? Have you had trouble sleeping? Have you been eating lately? And things of that nature to kind of get like a generalized score and a scale for how their emotions and their mood is. But I like to dive deeper in that. Like, when was the last time you had someone come to visit you? or who's in your support system. Tell me about any church members, neighbors, family, friends that are in your support system to kind of see, to paint a bigger picture for me. Like, do I need to contact the daughter? Or, can I speak to your neighbor if you give me permission to see about how we can get help for you in the home and things of that nature?
Did you create kind of this one pager out of necessity that there's so much information you need to collect and you have to do it in a short time? And I mean, I could imagine if you were to actually write up a report, it would be multiple pages. So tell me a little bit about how this one pager helps you assess quickly and accurately.
It really helps when I get back to the office and I'm writing out my progress notes. And depending on what employer, they may have a specific template for an assessment that's electronic. But because I have all of the information on a one pager, I can just plug in the information.
Mhm.
And then, like, if they note like a name of a daughter and like her phone number, I put that in my progress note in parentheses. So I like to make it, although it's like short and sweet, I like it to be detailed as well. That way, if someone comes behind me and they have to follow up, they know, okay, Miss Johnson has this daughter. Here's her name and number. I can follow up with her, and we have permission to speak to her. Or if the person doesn't have capacity, you have to speak to the legal representative. And then another part of this population is making sure legally, do they have a healthcare decision maker? Has the form been filled? Is it notarized? Do you have an advance directive or living will or power of attorney? We have to have that paperwork on file. And if not, I'm supposed to provide that to them and help them if they need help filling it out so we have it on file.
It sounds very complex. It sounds like there's a lot of moving pieces. And I have a question about coordination of care because you are one person, right? You're the social worker coming in. How important is it that you communicate with the nurses, with the care manager, with the case manager? It seems like it's a lot of wraparound services. So tell me a little bit about how you provide that multidisciplinary connection.
Yes, communication is very important as well as documentation. So every time I'm assigned a patient to see in the home, I have to attend a huddle. And you attend the huddle with the entire team. And that huddle is every morning, and they'll itemize like who was recently referred based on their start of care date. And then that's who we discuss at the huddle. So if social work is involved and it's a new start of care, then I have to be there and I hear from the registered nurse, physical therapist, occupational therapist, clinical director, our program director, and everyone. And we come together and discuss it. Like, okay, I saw her. She was able to complete some of her ADLs with minimal assistance or maximum assistance. Or yesterday she wasn't able to stand, but by Friday she was able to stand for 5 minutes. So, she's doing good. And they'll let me know, like, we're weaning her off of this and that. So then I know when I come in what I can support them on and how I can help the patient better.
So I come from a very different population. I work with children and kiddos. How did you learn about it seems like you'd have to have a lot of medical terminology knowledge too. Is this something you learned on the job? How can someone educate themselves just on the basics of what you need for the medical terms? Because we know there's a lot of complexities around the medical needs as well.
So for me, I'm a TV junkie. So I watch all of those medical dramas from like New Amsterdam, Chicago Med, Good Doctor, all of that. So I like that hustle and bustle, and I found it interesting. And some of it applies, in real life hospital settings and skilled nursing homes, but some of it is a little fictional for TV. But that helped prepare me as well as my own personal experience as a caregiver. My sister and I helped, care for my sick mom, and we learned about DME, durable medical equipment. We learned what a home health agency is because our own mother had like a home health agency come in, and she had the physical therapist and the registered nurse come in, and she had the oxygen, and we had to figure out, what is a bedside commode, because now all of a sudden we need this like for the home, and how to get the travel tank and go from appointment to appointment and hospitalizations and things of that nature. And we learned about hospice care. And unfortunately, we were really young at the time and we didn't have I don't even recall speaking to the hospital social worker or anyone to kind of help guide us through, like, what is this and this is the next step, or let's have that goals of care discussion. Like, the physicians are saying that there's nothing else they can really do medically, so let's explore end of life planning. And no one was really like helping to connect those dots for us.
Yeah.
So I find it interesting and necessary to help others do that.
How how is your role helping family members connect those dots or giving them the language? My own mother had to step in and care for both my grandparents, and it became a full-time job to just manage the different parts. And um, I don't come from that world, so I was always advocating, see if there's a social worker, see if there's an advocate. How much of your job is providing psychoeducation to family members or connecting them with people that can support them through this?
A lot of time is spent dealing with family members. And unfortunately, sometimes some people don't have family members. So a
Yeah.
lot of time is spent trying to explore that and just find people. And unfortunately, when you can't find anyone, then you have to do legal guardianship, and that's a whole nother process in itself. But I like to take the time to speak to a family member. A lot of staff may say, "Oh, well, this family is being difficult. The person's being like verbally aggressive or things like that." And I'm like, "Well, let's put ourselves in their shoes.
Yep.
If 30 days ago your mom was fine, now all of a sudden there's this life-threatening illness and they're hospitalized, and now they need X, Y, and Z, from medications to home health, or they may need to go to a facility. That's a lot to deal with." So I try to put myself in the family member's shoes and meet them where they are, let them know that, unfortunately, I went through something similar. Let's go through X, Y, and Z. And in a lot of those settings, they'll say, okay, the doctor will say the recommendation is for subacute rehab or skilled nursing home. And most families don't know how to select a nursing home or how to
Mm.
select a rehab facility. So I would come up with like bullet points, and I would talk to families about it and say, hey, the Center for Medicaid Services is a federal government agency that governs all nursing homes and rehab facilities. They have a star rating 1 to 5. 1 is the lowest, 5 is the highest. But since the pandemic, it hasn't been updated annually as it once was. So when I give you this list of nursing homes to look at, I would like for you to go over location, what's close to your home so everyone can visit the patient. 2, look at the CMS rating to see is it 1 to 5. But also 3, look at the Google reviews. What are
Mm.
the reviews? What are the images online? Speak to your community members to see, have you heard about this facility? Have you seen anything on the news about it, or etc. And also, I would tell families to call facilities. You can ask to speak to the director of nursing. You can ask to speak to a social worker at the facility, and you can ask certain questions. You can even ask to speak to food service. Because culturally, some people may want certain diets, and you can ask, does this facility offer that? Because my mom only wants like a Mediterranean diet or something like that. You can ask, like, do they offer these things? Or if you're very family oriented and your loved one is going to have a lot of visitors, ask them, what are the visiting hours? Can a relative stay overnight? Is the room private or is it shared? So I would try to help family members, and guide them through that process because it can be very overwhelming.
Yes.
And if
And
you're mentally
consuming.
clear, you have to be discharged. Like, they don't give you like days to think about it or, anything like that. Because insurance, we know that's crazy. And once insurance knows that you're medically cleared, they're like, okay, we're not paying anymore.
Yeah. One final question before I kind of pick your brain on what some advice you'd give to someone that wants to go into this space is tell me a little bit more about strength space and an empowerment model. It sounds like you do a lot of advocating, you do a lot of empowerment, but how does that tie into the work that you do? Because we know self-determination is really important and our geriatric clients have the right to self-determination. So how do you work from a strengths-based empowerment model with your clients?
Okay. I always like to focus on their strong points. Like, from the assessment, you figure out, like, what was their past occupation. And a lot of residents love telling you about that. Like, oh, I was a war vet or I was an engineer. And I love, speaking more about that and speaking of their strength. So, okay, so you're great with this, or you're great with that, and then see how that can help with their discharge planning and help them in the home. But self determination is very big, and unfortunately, some people may want to be discharged to stay in their home that they've worked hard to have, but medically and physically, they may need more support, which would mean like a skilled nursing facility or acute rehab or something of that nature. Or they may need like a 24/7 nurse if they want to stay in the home safely. So I would have to really respect their wishes, but also help let them know. And if it gets to be very complex, unfortunately, you may have to call Adult Protective Services if something is unsafe, or to have like wellness visits or things of that nature, or try to involve families to really help if they're really insistent on going back home if it's really not that safe.
So you're managing a lot of different pieces, right? You're making sure not only are their health needs met, but are their mental health needs met? Are they physically able? Is also the home set up to be able to support their needs? Because I know a lot of times maybe they have a two-level house and they're not able to manage that, or they need railings installed, or they need that equipment that you have. So it takes a lot of coordination of the different services and what is realistic versus what is doable, I think
Right.
is probably something that you're talking about a lot at this point as well. My last question is from a policy standpoint, you talked about insurance, which I can assume would be a very big barrier, and fixed income. What are some systematic or societal barriers that prevent this population from getting maybe the services or the support that they need?
There are a lot of barriers. One thing could be having like access to medical equipment. Sometimes the insurance may cover it, but they only cover a certain portion of what that equipment may cost. So then the patient is still left with a copay. And if they're already on a fixed income, it's going to be hard for them to get what they need to stay in the home safely. So if we had like access to more donated medical equipment, or if certain things were free, that would be amazing. Even little things like having like the adult diapers and the wipes and things like that. Some insurance plans cover it, but most do not. And those are daily things that you need every single day. And it's a new expense that you may not have once needed a few years ago that now you do need, and it's needed every day. So if we just have more access to different services like that, and of course food and nutrition, some neighborhoods and some populations are food deserts.
Yep.
So having access to like produce and vegetables is always a big need, or having it not only the access but making it affordable. I know personally, I've seen an increase in my grocery bill, and I couldn't imagine like if someone was older and on a more fixed income, it's really tough out here. And determining the amount of aid someone gets in food stamps, that has even fluctuated. I know
Mhm.
one person may get like $80, and another person may get $100, but we all know that's barely nothing when you go to the grocery store. Like that's barely fresh produce. So just creating more access to different avenues and needs would be a great thing that we could do as far as policy making and speaking with our legislative staff.
Yeah. So my last question is, if you were to give one piece of advice to someone that's interested or thinking about working with the geriatric population, what would be your piece of advice?
I would say have patience, and if you had a relationship with your grandparents or any elderly family members or community members, think of them,
Mm.
because sometimes it may be easy, but sometimes it may not be. But put yourself in their shoes. Like, you know, as adults, we've worked hard to build a career and a life for ourselves, and if suddenly that has to be uprooted and changed, it can be difficult to deal with. So just having that patience and that understanding will be very helpful working with this population and working in healthcare in general.
Yeah, that was great. Thank you. I learned so much because this is an area that's completely foreign to me. I've never worked in a hospital. I don't have any of the health language and lingo knowledge. So I was learning tons from you as well as you're sharing your experiences.
Thank you.
So I have listed some resources that people can check out about geriatric assessments. How can you put your clinical assessment skills to the test? What are what are some tools that you can use when you're working with this population that people can check out there? And Chandra, I just wanted to once again thank you for sharing your expertise with us. It is very apparent that you're super knowledgeable in this area and that you're also very passionate about this. And I think that that was very evident in the way that you were able to speak about the work that you do.
Thank you so much. Thank you for having me. Thanks for the work that you do as well.
Thank you so much. And for those of you that are tuning in, you will need to take your post test to get your CE credits and fill out your evaluation. So thank you for taking the time today to talk with us.
You're welcome.
I hope you enjoyed the Social Work CE from Agents of Change. Want to earn your CE credits for this course? Visit agentsofchangetraining.com or the link in the description to purchase the course and take the post-test. If you're looking for more CEs, check out our Unlimited plan. You'll get unlimited access to 150 plus ASWB approved continuing education courses for one low annual fee. We're always adding new courses and bringing on new experts. Did I mention we also have 5 free CEU credits available too? Check it out at agentsofchangetraining.com.